adequately examine patients. I've reviewed plenty of charts where the examination is substandard. It's a larynx cancer. Nobody bothered to do a scope and look at the larynx. I mean, those are things you really need to look at. It won't take you long to figure out. I talked to a colleague of mine today, and this is an amazing but true story. He is a reviewer for the state of Florida, as I have been in the past, and he reviewed a patient who had an APR for actually Crohn's disease a number of years ago. Well, the patient developed prostate cancer, and the radiation oncologist overtreated the small bowel, didn't realize the small bowel was, in the pelvis, didn't realize the patient had an APR. Apparently there was a rectal exam recorded. Don't ask me how that happened. But this is what he's telling me, and I know the physician that did it, and she was trained at a good institution. So these things happen. And so what I'm really cautioning you to do is, take the opportunity to look at the charts. I don't think that most practices will be insulted if you want to look at it. It's kind of a sign of interest. After you're done with your interview, and we'll talk about some of the things that you need to look for in contracts and things like this, it's perfectly acceptable to call referring physicians or non-referring physicians. If there's a doctor that doesn't refer to the practice, there's nothing wrong with calling him up. If there's a physician that you saw in the records, there's nothing wrong with calling him or her up to find out what they think about the practice and what they think about the doctors that are there. They will tell you a wealth of information. I've had this happen to me, and I always view it as a sign of interest from the applicants and always let the other practices know. We hope that during your interview that you have had a schedule of meeting with various doctors and not just medical oncologists. We hope that there has been an opportunity for you to meet ear, nose, and throat surgeons that will refer, pulmonologists that will refer, general surgeons that will refer, plastic surgeons that will refer, dermatologists that will refer to you if you become a new associate there. So those are kind of some basic tips and the things that we hope that you did before you get to a contract. So now let's talk about the principles of contracting. There's an article that I hope that Joanne will forward to you called Anatomy of a Professional Services Contract for Radiation Oncology. And one of the authors is a lawyer, so it is a fairly simple guide to contracting. And we'd like you all to have it, so hopefully we can get that email to everyone who's in this webinar. But a contract is simply a promise between two parties, which the law recognizes as a duty. Now, contracting is a dynamic process, meaning that it is not a, this is what's on the menu and you get, you can't have fries, you have to have mashed potatoes with your dinner. No. It's a dynamic process between you and the practice, or you and the hospital, or you and the other physicians. So, so kind of remember that. You'll need a lawyer. We'll talk about that in a minute. But some of the things that you need to look at in your contract, and yes, you need to read the whole thing and figure out which things that you're not clear on. No one expects you to be a lawyer, but make sure that you do read the whole thing. Try to understand it as best you can and guide the lawyer that you choose to the sections that you need help with. Some of the things to look at and some tip-offs for you are to avoid vague provisions that allow your employer, which could be the hospital or it could be another radiation oncology group or it could be an academic center, to change the rules as you go along. For example, I've seen many contracts that are written that say something like, you as a physician are to abide by the rules of the board of directors as they are made from time to time. Well, they could decide that, you have to shave your head now, or you have to wear a suit every day instead of just a tie and a white coat. So I would say that, that's kind of a moving target, and it's not something that you want to be subject to. So you don't want the rules changing over time and changing at the whim of the board of directors. Now, there are some exceptions, and those include Medicare laws, which unfortunately are constantly changing. So you have to abide by that. You have to abide by the Medicare rules, by the Medicaid rules, and those are a moving target. They do change. The other exception is tax law. Well, you have to abide by the tax law as written, and tax law changes gradually over time. So those things may or may not be in your contract, but those are, pretty something that you can expect, and I wouldn't necessarily get too worked up over that. You're going to need a healthcare attorney, and notice that you're going to need a healthcare attorney. It's not your brother-in-law who does family law. It's not your, friend who does, business contracts, or your friend who is a corporate lawyer. You need actually a healthcare attorney who either specializes in healthcare or has an interest in healthcare. Healthcare actually is a board certifiable specialty in many states. You may not necessarily need someone who's board certified in it, because in Florida I think there's only 22 or 3, but you need someone who regularly reviews contracts for physicians and can kind of understand the things that doctors go through, the things that you need to look for, and the traps that there are for you, either with a practice or with a hospital. So where do we find a healthcare attorney or someone who's specializes in this? Well, start with your state and local medical society as a resource. Just like physicians who are new, healthcare attorneys or people that have an interest in healthcare will end up signing up or being listed with a local or state medical society, and that's usually a good resource. Spending money on an attorney is some of the best money that you can spend, so just kind of keep that in mind. You are going to have that as an expense. You have to read the contract first. I remember my sister taught me, my sister's also a physician, that attorneys always need hand-holding. They need hands-on management, I think is what she told me when I was younger. And unfortunately, she's true. It's true. You have to guide them. You have to direct them. You've got to read the contract first. You've got to point out to them what the areas that you're unsure of, and they may actually negotiate on your behalf. Your attorney and the practice's attorney can negotiate together. Usually attorney to attorney, they can be pretty diplomatic, we hope at least. Choose one that is. And usually, one point of view can be expressed so that you don't necessarily have to go back to your physician or your hospital with each thing. So find a good attorney, find one that is easy to talk to, and let them do a little negotiation on your behalf. If it comes down to 1 or 2 points that are very important to you, certainly negotiate with the hospital or the physicians as you go along. You probably don't think that understanding billing and collections is terribly important, but I'm here to tell you that it really is. One of the things that I want everyone to understand is that when an error is made on your behalf, so if someone else bills for you, whether it's a service you provided, didn't provide, whether you knew it, whether you didn't, it still is essentially your fault. It's on your head. So when you join a practice, when you enter into a contract, it's important to spend some time to understand billing and collections. And there is not a lot written on this for radiation oncology. You can read the ACRO billing collections guide. At this point, I can't remember what it's actually called, something like that. That's very complicated, and I would say it's not for beginners. I would recommend that everyone, and it's not too long, I would recommend that everyone read the economics section, the economics chapter in Principles and Practice of Radiation Oncology by Brady and Perez. It's chapter 100. It's not particularly long, but it is particularly pertinent, at least I think so. The other references that you might consider are there's a book called The Encyclopedia of Radiation Oncology. I don't think it's out yet. There's 2 chapters written in that on economics and billing and collections. The American College of Radiation Oncology had a practice guide, or has had practice guides over the past probably 20 years. And they're always chapters on billing, collections, and economics in those. But I think probably everybody has this textbook, or if you don't, you probably can get your hands on it, and I recommend that you just take a look at it. It'll contain information that you never have seen before, and I think that's why we're here. Okay, so to talk a little bit about billing and collections. I don't want to lose you here, so I don't want to make this boring, but again, this is important. First of all, let's talk about billing and time. All right, and time is money. The practice is going to bill Medicare. Medicare is going to pay 80% of the patients allowable, so 80% of the bill. It's done electronically, and it will be collected in 14 to 17 days. I actually have this down to 14 days, sometimes 13. So if you're efficient and you're good, you can get something collected in less than 2 weeks. The secondary, which is the insurance that is not provided by Medicare, pays the additional 20%. That's billed either electronically or, oh yes, by paper. So we send envelopes and packets of paper to an insurance company, even still. And that actually takes 4 to 12 months to collect. So I want you to understand that there's a time delay in when you get paid. That's going to be important. Private insurance like Blue Cross Blue Shield or United Healthcare or Aetna or Humana, they are billed either electronically or, again, sending packages of paper to the insurance companies, and it will actually take 4 to 12 months to collect. If you bill electronically, it can be faster, but insurance companies are in the business of delaying payment because that's actually how they make money. Medicaid is the worst known to man. I've been a reviewer for Medicaid in the state of Florida. I know how to access them. I know what buttons to push, and still it has taken me 3 years, 36 months to collect for various things that are, certainly within the standard of care. So I want you to understand that sometimes, yes, you can be 3 years out. And that money that is out there makes up something called accounts receivable. We're going to talk about that later when we talk about partnership. When you bill under Medicare Part A, now remember Medicare has 2 parts, Part A and Part B. Part A is for the hospital, so it's for hospital-based practices and hospital-owned practices. The Medicare codes are both professional and technical under Medicare Part A. So professional codes are for those codes where the service is rendered by the physician personally. So for example, an office visit, or what we used to have several years ago, was a consultation by a specialist. So the patient comes in, they will see you in the hospital-owned, hospital-based practice, and you will be able to collect a certain number of dollars, about 160 or so, for that office visit at the highest level for rendering your opinion for the first day. That actually has no technical reimbursement. It's professional for the doctor only. So we're going to contrast that with what is collected under technical reimbursement. Well, the technical reimbursement is for the equipment, basically. So a code where you would collect technical only would be something like IMRT treatment delivery or any radiation oncology delivery in a hospital setting. Okay. Now, there are certain codes that are a mixture of both. For example, isodose plans have a technical component, and that component is paid to the owner of the equipment or the employer of the dosimetrist, or both, which would in this situation be a hospital. But it requires a physician to look at it, approve it, check it, reject it, send it back, have it redone. And so there's a professional component to that as well for the doctor. So that is actually, so the professional component is billed by the physician in hospital-based practice, and the technical component is billed by the hospital, the owner of the equipment. Now, when you are in a hospital-based practice, you as a physician will do your own billing, or your group will, and the hospital will do their own billing, because these things are separate. There's a professional component again for the doctor and a technical component for the hospital or for the owner of the equipment. There are some problems for the codes that are mixed. So for those who have professional and technical, it actually depends. Medicare many times won't pay unless you guys get your act together and bill at the same time. So these are kind of the things that you need to look for when you are looking at a practice, and certainly at the point that you are going to become a partner, because you can see that missing the opportunity, or if a hospital misstates their code on the same day that you're doing yours, and they don't get it right, and hospitals are notorious for this, neither of you get paid until you guys straighten it out. So it delays things and kind of gums up the works. So I want you to kind of understand that. Wait a sec.
Dr. Schilling, I think if you click on the next
Here
slide.
we go. Okay, I got it. Okay, sorry about that. When you bill under Medicare Part B, that's for outpatients in general, okay? And Medicare Part B is billed for freestanding cancer centers. So anyone who starts a freestanding cancer center, and that can be a hospital if it's apart from the hospital, not physically associated, so not on the hospital campus, or a group of doctors who start one, or any sort of medical group, or anyone. So billing under Medicare Part B is for freestanding centers. There is a bundled professional and technical payment. So in other words, instead of billing for the professional for the doctor and billing for the technical for the hospital, like we talked about in the previous example, you just bill one single code, and then everyone gets to, you get to figure out and divide it. So the physician's not able to actually bill independently on his own for just the professional service. It's bundled. Again, there are codes that are professional or technical only, but there are also codes that are mixed together. So for example, I'll use some code numbers for you. 77295, which is radiation three-dimensional treatment planning, has a professional component for the physician input and the technical component for the equipment owner. So it's important to know how to split that out. If you're kind of in one pot, how do you decide what's the professional technical component? Well, hospital contracts, or I'm sorry, an entity contract that owns a freestanding center that employs doctors will usually tell you that they will give you a certain percentage of collections that is the professional component, and that averages between 11 and 35% of the gross. So it usually falls out about 22%. And I'm going to give you a reference. It's page 1838. Again, chapter 100, Principles and Practice of Radiation Oncology. If you're negotiating with an entity that owns a freestanding center and they are negotiating with you in this way, that's the information that you need, okay? Let's talk a little bit about the terms and conditions of contracts. Again, the contract should spell out a few things. One is your hours. What are the call arrangements? I want you to take a look at call provisions. And for a long-term contract, in other words, for a multi-year contract or even for a single year, It shouldn't say that the call will be 1 in 3 if there's 3 doctors in the practice, or 1 in 4 if there's 4 doctors in the practice. It should say that you all share and call equally. That way, if the practice adds a doctor, it can be 1 in 5. You don't get stuck with 1 in 3, that sort of thing. It also should spell out what the provisions are for paid time off, which employers previously used to call vacation pay, but we don't do that anymore. So it should spell out what the provisions are for paid time off, for coverage, for continuing medical education, for what is the reimbursement for continuing medical education. In other words, does the practice pay for it? Some important things to kind of look at are ancillary staff. How is the practice staffed? Does it look to be overstaffed? That's just as important as does it look to be understaffed? And who determines the staffing component? Is it one single partner? Is it the hospital with one single person who determines that? And the real question is, do you have some sort of input? What kind of input do you have with that? And if you're going to get some input, when would you get that? Because that is going to be important to you. This is your day-to-day practice environment. Is there access to a pension plan? There are hospitals will have one type of pension plan. Freestanding centers will, may have another. Is that important to you? I would say if you ever want to retire, you really ought to consider putting some money in a pension plan. So that may be important to you. I don't know. One of the things that you need to look at is, are you an employee, which most of the time you are, at least from what I'm seeing these days, or can you be an independent contractor, as I was when I worked for a hospital initially. An independent contractor really is a tax law term. And all it means is that you are contracting your services to this entity. All of the expenses associated with that entity are now yours. You get to deduct them from your taxes. But you also have to pay out of pocket for things like professional liability insurance, your own CMEs, your own vacation time, all that stuff. I think probably the one plus point to being an independent contractor, if that's even available to you, is that your pension plan you can put considerably more money into a retirement or pension plan if you set it up yourself. Let's talk a little bit about the term of the contract and the termination. The termination is something, and I see termination clauses are something that are very variegated. So I want you to pay attention to what I'm saying here. I think that any reasonable physician would understand that you get terminated if you lose your medical license, if you get convicted, not just accused, of a felony, if you lose the ability to prescribe narcotics, if you lose the ability to prescribe in your state. These are things that impair your ability to practice and usually mean that there's something seriously wrong here. So to terminate you for cause, and those things are all cause-based, you did something and now you can't fully practice as a physician. To terminate you for cause is certainly reasonable. A doctor can't practice without a license. I would say we can't practice without being able to prescribe narcotics. God knows I couldn't. If you lose your prescribing ability, or if you lose your ability to bill under Medicare, which usually means you did something wrong, you can't continue to practice. You can't be valuable to the practice. So you can get terminated for those things, and let's hope you don't encounter them. There are some things that you need to watch for. If there's a felony clause in there, I went through this, but make sure that you're convicted of a felony, not just accused of one. In Florida, I think if you are over a certain speed limit, it's a third-degree felony. So be careful of, be careful of what you're doing. And again, a lawyer will be the one to help you with this. I have seen, I've seen what I would call out clauses. So, either you as the employer or you as the physician who's being employed get some sort of out clause. So it may be a 90-day kind of no-fault thing where I, as an employer, can release you with 90 days notice, or you as a physician can be released at 90 days notice. I've always really felt that those were dangerous because it looks like you're not even dating. You haven't even made a commitment here. And I have never signed one of those with anyone, even though people have asked me to do so. I think that it kind of represents a lack of commitment on both parts, and many people will say, well, it cuts both ways. The practice can get out in 90 days notice with no cause, and the doctor can get out with 90 days notice and no cause. But, I think that at this point in time, we hope that you've gotten to know each other better enough so that we hope you've gotten to know each other but well enough so that you don't need to resort to that. And again, for people who have moved to a new area or you have family or whatever it is. Hello? So, I want you to kind of pay attention to those sorts of things as well. So the contract should spell out what the terms and conditions are and how you can be fired. One thing that I want you to understand is that when your billing entity, whether that be a hospital or whether it be a physician group or whether it be a national group of some, or even an insurance group. I worked for a hospital that was owned by an insurance company once. When they make an error on your behalf, you, the doctor, are the one who's liable for those errors. So it doesn't really matter if you knew or if you didn't know. That's why I kind of started this with a hint to try to understand the billing process. It's really not necessarily all that hard. But one question to ask and one question to look for is the practice had any outside agency looking at their billing processes. Many times, a practice will do this. They may hire an outside consultant. They may actually hire one through a lawyer, which makes it not discoverable if they're making errors, and the practice can then fix it in a quiet, diplomatic manner, I guess is the best way to put it without raising red flags. But I think many practices have had outside agencies look at their billing process. Is the practice that you're going to certified in any way? Is it certified by the American College of Surgeons? Is it certified by the American College of Radiation Oncology? Is it certified by the ACR, by the American College of Radiology? So that may or may not be important to you and may or may not be important to the public, but those are some of the things that you want to take a look for. You may not necessarily need to ask. I know that American College of Radiation Oncology publishes all practices that are certified on their website, so that's an easy thing to find with that entity. And I think that the College on Surgeons does the same, at least they used to several years ago. Let's talk a little bit about restrictive covenants, otherwise known as non-compete clauses. And you may have heard a lot about this. I remember when I was in your shoes, I would hear that restrictive covenants or covenants not to compete were not enforceable in Texas, and they were not enforceable in California. Well, I'm here to tell you that any restrictive covenant, depending on how it's written, can be enforceable in any state that you go to, and there's not an exception. But the real question that the court will have in either enforcing this or not enforcing this, we're going to talk a little bit about how not to get here in a minute. But I want you to understand the mechanics of it. The way that the court will interpret this is, number one, is there a public need for your service? So are you in Manhattan and there is a radiation oncologist every 5 miles? Or are you in Ketchikan, Alaska, where there may only be 2? Well, if you're in Alaska or you're in a place where there's only, 1 or 2 or very few, the court will may decide, not will, but they may decide that there's a public need for a specialist like you, and they may not necessarily be thrilled about enforcing a non-compete. Um, and the next thing to look at is what is the time frame and what is the geographic scope. Again, if you're in Manhattan, and there's a non-compete clause, a geographic scope of 5 miles, so no competing 5 miles within the practice that you leave, may be very reasonable. If you said 60 miles, well, the New York metropolitan area is pretty far and wide. That doesn't seem to be, that may not seem reasonable to a court or to a jury, which will ultimately hear this. So you kind of, what I want you to look at is if there's a non-compete clause in your contract, and there are good reasons for them, try to make sure that you narrow to geography, so make the distance as small as you can, and the time, so make the time as short as you can. A year, 2 years, 3 years, but not 7 to 10 years. There, we don't, I want you to pay attention to this now because you don't want to get into a situation where you leave a practice, your husband or wife, has to stay in the area, or you have to stay in the area, or whatever, and now you're kind of stuck. Whatever you sign, whatever you agree to, whatever both sides agree to is kind of what you should plan to stick to. If you are planning to leave a practice and set up shop across the street, and you have a non-compete clause or a restrictive covenant, expect to be sued. And one of the things that I never really understood what it meant until later in time was people would talk about whether this entity has the ability to sustain a lawsuit. And I would think to myself, well, anyone can appear in court constantly, but what they're really saying is, do you have the money? And to reach a jury, the cost of trials is fairly expensive, and we're talking maybe 90,000 at the bare minimum to 300,000 to 400,000 as kind of the average for a jury trial. And probably many lawyers would tell you it can be more than that, and I think that that's probably the case. So you want to try to make sure that you don't get in a lawsuit about this particular thing. Whatever you negotiate, try to reduce the time, try to reduce the distance, and try to understand that when you're done, you have to, when you sign it, that you should abide by it. Now, one of the things that I've noticed in a lot of contracts these days is that there's something called a liquidated damage clause instead of a non-compete clause. So instead of the contract saying, I agree not to compete for a period of 3 years and a radius of 25 miles, this will say, I agree not to compete with the practice after I leave, but if I decide that I want to do that, I will pay the practice a lump sum of $300,000, and that will essentially buy my ability to compete. And I will tell you right now, liquidated damages clauses are enforceable anywhere. It is a common thing of law to have something like this. And if you sign one of these and you decide to compete, expect to pay it, because you'll not only pay this, but you'll pay your opponent's lawyer's fees as well, or sometimes you will. So again, plan to stick to what you decide to sign. Let's talk a little bit about compensation formulas. How do you get paid? Are you going to be on a salary for the first year? Is there a salary plus some sort of productivity bonus, some sort of incentive? If you're on a flat salary for the first year and you don't have an incentive, and I'm not necessarily seeing a lot of these days, especially in the first year, I'm here to tell you that nobody expects you to sit on your hands every day and show up at 9 and leave at 4. Most practices will expect you to do some things to build volume. That is going to be one of your jobs. So I want you to understand that. And that means meeting doctors, making appointments with physicians to meet them, eating in the doctor's lounge so that you can meet physicians, giving talks to the public, giving talks to the local medical society, attending tumor board every time, giving lectures in tumor board if available. So I want you to understand that those are the things that people expect a first-year associate to do. Again, take a look at Chapter 100 in Principles and Practice of Radiation Oncology, and look under the section that says marketing. I think it's how to start a practice, how to market a practice, and how to sell a practice. Look at those 3 sections. The next thing to consider, if there's a productivity bonus, what are the expenses that are subtracted from that? Well, let's talk a little bit about expenses that are imputed. If it's a hospital-based practice, it's hospital-owned, the hospitals actually will employ the physicist, employ the nurses, employ the dosimetrists, and the physician bills professionally and has only the cost of billing, professional liability insurance, etc. Okay? So for hospital-based practices where the physicians bill independent of the hospital, and that's the ones where you have to make sure you got the billing dates right, look for extra people employed by the group. Are there, is there an extra nurse employed by the physician group? I tend to think those are bad situations, especially if you have extra people aside from billing personnel, and I've been in this situation before. It usually kind of means that there is a hospital who won't be reasonable to hire another nurse or hire another med tech or hire, somebody else to help you. And the physicians throw up their hand and say, okay, I'm going to hire a nurse and the hospital will be fine with it. That kind of makes for a difficult situation. I think it speaks volumes about the hospital itself. In a freestanding center, all of the equipment, all the personnel are paid for by the practice. So everybody, including the physicians. There are, and I haven't seen this in a while, but there are certain practices that will actually own boats to take referring physicians out to. They'll own artwork that's displayed in the cancer center. And these are really kind of tax issues that I'm talking about. But did you really want to, have $300,000 go out the door for a boat? And, if the practice owns a boat and your job is to entertain referring doctors on the boat, can you drive one? Are you a captain? Do you get used to bid a third if there are 3 partners? These are the kinds of things to take a look at. Well, let's talk about professional liability insurance. And this is important in your contract. It's important to understand how this covers you, and it's important to know what happens if you leave a practice. I wrote an article, that was published probably 93 or so, and I don't think it's changed much, but at that time, only a third of the radiation oncologists that entered their first practice after completing residency were still employed in that practice 3 years later. So what I'm saying is that 2/3 of people left for whatever reason. Certainly it's not necessarily that they didn't like it. It could be they needed to move or their mom got sick or whatever. But a lot of people, there seemed to be a lot of movement at the time, and I think within the past 5 years that's still true, although I don't know what's gone on from 5 years to today. But professional liability insurance is something that no one really explains to you, so I'm going to try to do that. The first type is called claims made, and what that means is if I'm insured in the year 2014, any claim for a patient made in 2014 will be paid. So I've been in practice since at least 93, maybe 92. So if I now have a claim from 1993 because someone has a dry mouth from head and neck cancer treatment and we didn't have IMRT then, that in 2004, when I have my insurance, that claim will be paid by my insurance carrier. If I have, so that's what's called claims made. If I have occurrence, then if I'm insured for the year 2014, that means any episode of care that I delivered in 2014 will be insured in 2014 and until the day that I die. So in 2021, if someone makes a claim and I've had occurrence insurance in 2014, that claim in 2021 will be paid. Okay. So which is the better deal? Well, let me just tell you that occurrence policies, and that's the one that pays for everything forever in the year that you're insured, um, are becoming a thing of the past. Some hospitals like HCA will have occurrence policies, and that's good for you if you work for them. I think they self-insure or they have their own insurance company. But many times it's not the case. So I would say the majority of practices, vast majority, are claims made. So if I decide to leave a practice and I'm insured in 2014 for claims made in 2014, what happens if I leave? Now I don't have the same insurance in 2015, but now someone makes a claim in 2015. Well, the answer to that question is you have to purchase, notice I said purchase, a tail policy. And what that tail policy does is that insures you from 2015 when you leave the practice. You're going to work 2014, you're going to leave in 2015. That insures you from 2015 to the day you die. Now, that sounds good, but what I want you to understand is that a tail policy that actually covers you until the day you die not only costs money, but it costs about 3 times what your annual cost of professional liability would be. So my current insurance is around, I think about $15,000 a year, fairly low. But my tail policy would be, if I decide I want to move to Colorado tomorrow, would cost me $45,000. So that would actually insure me from the point of leaving Florida for the rest of my life for anything that happened in Florida from my practice beginning 1993 until the day that I die. But you can see that when you move to a new practice, you have to be able to insure that risk. And insuring that risk means buying a tail policy. And when you go through your contracting process, you need to know who buys that. Do you, as the person who may leave or may not achieve partnership status, buy it? Or does the group buy that policy for you? And if the answer is you, I just want you to understand that you're going to be laying out some fairly big bucks to do this. If you go bare, and I'm sure you've heard about this, if you don't have professional liability insurance, there's 2 things. One, many hospitals will not allow you to be on staff without it. So when you move to Colorado and you are not insured into the future from Florida, you may not be able to get on hospital staff. And the second thing is many states will not allow you to practice, and Florida is quasi one of them, without professional liability insurance. Technically in Florida you can, but it's incredibly difficult. Basically you've got to have, I think, around $400,000 in a bank account to do it. So I want you to understand that if you leave a practice, you have to have a tail policy. What if you practice successfully for 20 years and you leave, then what happens with that tail policy? Well, in the past, and it's true for my carrier, if you retire after, I think it's about 10 years, your tail policy will be included if you never practice again. So these are some of the things to know and some of the pitfalls to understand if you happen to leave a practice because things don't work out. All right, let's talk about shareholder status or partnership. Partnership is simply, essentially, parity. There's voting parity and there's financial parity. So the first question to ask is that a graduated partnership? Does it occur gradually over time, or is it after 3 years you become equal partners with all the physicians in the hospital? How is that working? Again, look at voting partnership and financial parity, or voting parity and financial parity. Again, take a look at the expenses. One of my favorite tricks of a hospital, this is a true story, you may not believe it, The hospital that I worked with was not profitable, but I was treating myself 40 patients a day on 2 linear accelerators. Well, how could that be? Well, the answer to that question was they cost accounted the cost of the cafeteria, which was a loser, in the hospital, to my center. So suddenly they sucked up and soaked up all of the profitability of that hospital. So did I get paid only after all the expenses were paid on the profit that the hospital determined? The answer was no. I got paid on the gross. So even though they did that and it choked off the ability to upgrade and buy new equipment, um, that stuff happens. So I want you need to kind of know that. The accounts receivable, remember that money that's locked into the billing cycle that can take up to 3 years to collect that we talked about. Those are some of the things that various practices, including hospitals, will want you to buy into. In other words, they'll say, okay, well, your billings going forward might be $100,000, and we want you to pay that, and then you'll become a partner. And private practices will do that as well. And kind of my answer to that question is, if you're going to be made a partner, hopefully you increase the patient volume, you increase the volume of practice, that's your job. So those accounts receivable, those things that haven't been collected but have been billed under you, probably aren't something that you should pay for because it's a benefit to the practice. And you warrant financial parity for, let's say, several years. And so, that kind of is, one contribution that you've made. Um, if you are looking at a buy-in, again, that's a lump sum of money that you would pay a practice to join them to become a partner. What are you buying? Well, if it's a hospital-based practice, we talked about buying the accounts receivable. I think that's a no-no. I think that you buy hard assets. If you're going to buy something, you should be buying a linear accelerator. How would, an HDR machine? Those are the kinds of assets that you would buy, that you would pay for, that a bank would charge you for, that you get a bank loan for, to buy into a partnership. So think of hard assets to buy into. Um, I don't think that it's necessarily fair to pay any money for a hospital-based contract that another group of physicians has. That's only my opinion. Again, the professional component is professional component only in a hospital-based practice that bills separately. So again, you want to consider buying in for hard assets. What about buying in for some sort of exclusive contract with either an insurance company or a hospital? Again, I don't think necessarily that that's something to buy. Again, just think of hard assets like linear accelerators and HDR machines. Okay, what are the terms of shareholder or partnership for freestanding centers? Determination of what the assets are, again, linear accelerators, things you can, actually purchase, HDR machines, PET-CT, CAT scanners, simulators, those kinds of things. There's a determination of assets that can be done. You can see what everything's worth. You can pay a pro rata share depending on how many doctors. So in other words, determine how much the equipment's worth, divide it by 4 if there are 4 doctors, and you pay your part. You usually get a bank loan to do that. Again, at the point of partnership, you've got to kind of look at those expenses. Are you supporting the main physician's wife at the tune of $100,000 and you never see her? She's a nominal employee. Is there a boat owned by the practice? I will never forget being asked if artwork was owned by the practice. That was actually mine personally. That wasn't the case. And again, we talked about the account receivable, which is the money locked in the collection cycle. There are a number of jobs that are non-partnership track. I don't really know what to say about them. They did exist when I came into practice. I would say that they're essentially training grounds for you if you need to be in a geographic area where a non-partnership track is offered. I'd say use it, learn something, learn how to build a practice, and learn those skills so that if you go to another practice, you will have mastered them. Academic positions start from, in my opinion, a disadvantage. There's something called the dean's tax, which is a percentage off the top of all of the department's collections. It can be 10 to 15%. And so essentially the dean takes that off the top, then their expenses, then their physician salaries, the money trickles down to you. So think of it like living in California. 13.9% income tax, you're at a disadvantage to start with. Hospitals, again, are notorious for cost accounting losing services to the radiation oncology department to reduce the profitability. It's kind of a game that they play. I would say it's pretty prevalent. Again, many of you will not stay in your first practice for one reason or another. It may very be, life changes. So what happens if things don't work out? Make sure you have a tail policy. Make sure that's negotiated in advance. We talked a great deal about that. Leave on good terms. There's no reason to disparage the practice that you're in, even if that may be warranted. Just tell people that you are not the right fit for the practice, or you are not the right doctor for the practice to work in. And just again, try to leave on good terms. You would be surprised how many people will call either the previous practice when you want to have when you are interviewing for another job, or they'll call referring physicians from that practice unassociated with the practice that you worked in to find out what you're like to work with. And if you leave a trail of bad will, it will catch up to you. I think we've got 5 minutes, and I don't see any questions, and I don't know if we have the facility for anyone to ask them. Joanne?
I don't think anyone can ask them through the audio, but everyone is welcome to type in any questions under the chat box at the bottom of the control panel. And while people are coming up with any questions they might have, I did want to ask you a few questions. One of them was regarding some of the contracts that you discussed. And in your experience, being on both ends of the contracts, offering to physicians and reading them yourself, how flexible do you feel that they are? Because I've definitely heard some conflicting things from other residents saying that they are not negotiable, or that many times they are unable to be changed. Have you experienced that as well yourself?
Yeah, I mean, the answer is yes and no. I would say when I, negotiated with hospitals, they were relatively inflexible. It took, finding the right lawyer, finding the right hospital's lawyer to make them understand my point of view. You want to have a healthy relationship. I mean, this is going to be a relationship. You want to have a healthy relationship. You want to have everything work out for everyone. So if you have a concern, what someone is telling you from the start is that your concern isn't valid and they're not going to move. So do you really want to work there? I mentioned that I have had people ask me, and I have said no. So in other words, I'm saying that I've been inflexible. I have had people ask me for the reciprocal 90-day out contract. So I get 90 days to fire them, and they get 90 days to fire me. And I just don't think that that's really quite exactly fair to anyone. I think that you ought to make a commitment for at least 12 months before you figure out it's not going to work, because I don't think 90 days is enough for anybody, for either party. So I've been inflexible with respect to that. Otherwise, I don't really, I really think that it is a negotiating process, and I think that some people may want to stonewall you, and they may want to, just have a one-size-fits-all, take it or leave it. How to get through that. Sometimes you can get people to move by, blaming the lawyers. Oh, my lawyer really said this is important. I don't mean to make you upset. But he's concerned about the practice well-being, my well-being, your well-being, whatever it is. Sometimes you can negotiate that and kind of move people along with that tactic.
Okay, great. We do have some questions coming in, so please continue them. One of the questions that was asked was, this is a little difficult. Where do you recommend getting information about salaries in each geographic area? Do you happen to know of any
Um,
resources for that?
yes. The American College of Radiation Oncology did a salary survey, and it probably is 5 years old. Um, and certainly things have changed a lot in medicine, but I think you probably still can get it if you're a member. Um, it is, Having said that, that's kind of the blended salary over, for each geographic region and for every stage. So someone who's been in practice as long as I have, we hope is making more money than someone who's just coming out of practice. But I would say start there. And other than that, I don't know any official resources.
I do know that every year there is something at ACRO for the residents that does happen on the Saturdays, but that's overall for the entire nation.
Right.
Yeah.
Do they actually have salary surveys though?
There is a salary survey for first year residents, or that first year residents that just graduate, correct? Mhm.
Okay. And I think actually Dan Flynn does that, doesn't he?
Yes, correct. Yep.
Yeah, yeah.
All right. The second question. This is a good question. What would you say is a typical or a fair number of years to work before you become a partner? And the other question is, why do you think hospital employee positions are on the rise when compared to private groups?
Okay, well, let's do question number one. What do I think is a fair number of years? Well, it doesn't really matter what I think. It matters what your, area is going to bear. So if you're in Manhattan and you're stuck in Manhattan because you have to be there or you want to be there, it may be, 5 years of partnership. I don't know. I've certainly seen that before. If you are in central Alaska where it's cold and miserable all year, it could be a year. Um, my practice, it's been 2 years for 20 years. And I think that, that's very reasonable. I would say it takes a year for everybody to get to know each other and then a year to make sure that we can work together. And then I think, you got to know by then, both parties ought to know by then. Um,
And the second
and the
question,
second question, I think, was, oh, go ahead.
yeah, the second question was, why do you think we have more hospital employee positions than private group positions? Dr. Schilling?
Is that radiation oncologists or in general? That bode for the radiation oncologist? Well, I don't know the answer to that. It may mean that if a hospital is bought or if a hospital buys practice A, they will coerce, however illegally, the doctors in practice A to refer to now the hospital-based practice and not the freestanding practice. I don't know. I've been on both sides of that equation, and I can tell you that surprises always abound. There are hospital-based, when I was a hospital-based doctor and hospital-based doctors referred to me. Sometimes they didn't for reasons which elude me, despite the fact that they were employed by the hospital. And sometimes they did. And when I switched and became freestanding or got out of the hospital practice but stayed in my community in a freestanding center, there were doctors that, were employed by the hospital that always referred to me and never referred to the hospital, and the other way around. Um, I think that there is a substantial trend in uncertainty in medicine, but I will tell you that I think it's been around since I graduated anyway. And, people are looking at who is the winner and who are the winners and who are the losers for Obamacare. And I can't necessarily tell you, who those people are. But some people think that the hospitals are the winners, and I think that it's true that they're the beneficiaries of, more insured patients who otherwise use the emergency room and were uninsured. So suddenly, instead of having an uninsured patient, they've got a patient who is Medicaid. At least they get paid something. So that's what it's looking like, to me to sort it out. So hopefully that answers your questions.
Okay, I think we have time for one more question. As a as a new physician in a practice, what kind of support do you think is reasonable to request contractually to develop your practice?
Um, I would say that you first have to have a plan. So I think what you're telling me is I want to go out and develop a practice, well, what's your plan? So what do you want to do? If you want to go give talks to the American Cancer Society, well, that the support for that might be punch and cookies. That doesn't cost you much. If you want to go to tumor board, that doesn't cost you much. If you want to go bring lunches to physicians, I would say that's a no-no. You're a doctor, go visit them, don't bring them lunch. So it depends on what your plan is for how you want to build the practice. If you decide that you're going to give a national talk, well, that's great. You'll be in front of radiation oncologists nationwide, but the $3,000 or $4,000 spent there is not going to enhance the practice where you're living. And your audience is not other radiation oncologists to refer to you; it's other physicians.
Okay, thank you very much, Dr. Schilling. To all the participants, thank you for joining us today. I'll be emailing everyone with the attachment for the second reading material that Dr. Schilling has written with the lawyer, Andrew Woods. And please email me if you don't get that document from me by tomorrow. This is Joanne Zhang. And thank you, everyone, and have a good night. And thank you, Dr. Schilling, again for joining us today.
You're very welcome. Hopefully it was helpful.
Thank you, it was. Bye, everybody.
Good night.
Good night.